most of my patients are somewhere between the age of like 15 and 50 or something. And so for a lot of the younger end of that spectrum, autograft is the best choice. And so I'll take either BTB, which is the patella tendon, or I'll take the quadriceps tendon, which is right above the kneecap.
Okay.
You can take a little segment of that. So if someone fails at the BTB, sometimes I'll take the quadriceps tendon without taking any of the bone, just take the tendon itself.
So you just slice out a little piece?
Yeah, a little, like about a centimeter thick. It's a small portion of the quadriceps tendon.
And then what, you sew that back together?
Sew it back together, and it heals beautifully.
And then like they don't know any different from that?
No, the knee functions just...
Andy.
Thanks for having me.
Yeah, dude. Super excited.
Yeah.
I know your brother from just the coffee shop and working out over at Marcus's. Yeah. And when he was telling me that you were an orthopedic surgeon, I was like, holy shit, I have so many questions. I had just listened to the Rogan, Brigham Bueller, I think is his last name.
Yeah.
And they were talking about stem cells, and Joe, I guess, had some shoulder shit going on. And I had torn my ACL in high school, and I still deal with issues from that.
Right.
So as soon as they started talking about stem cells, I got super interested because, you know, surgery sucks. It's like super invasive.
Absolutely.
I still feel like I have all this tightness in my knee, right?
Yes.
And like muscle stuff, ligament stuff. So anyways, I just thought it would be super interesting to sit down with somebody who's obviously knows a lot more than I do. And yeah, so why don't we just start out with like a little bit of a background kind of, you know, story and kind of give everybody an idea of like what you do and how long you've been doing it and all that kind of shit. So go ahead.
So I'm an orthopedic surgeon. I've been in practice for about 5 years now. My specialty within orthopedics is sports medicine. So specifically the stuff you're talking about, like ACL reconstruction. We take care of a lot of different athletes and athletic type injuries. So stuff that you can fix with an arthroscope. So you can do like a little 4mm scope that you stick into the shoulder. And it's sort of like, it's like building a ship in a bottle, because you're working through small holes to fix, you know, big problems.
Right.
So do a lot of that. But obviously for athletes, surgery is sort of your last recourse, because most people don't want surgery for the exact reasons that you're talking about. Because when you go into a knee, you can fix the problem, but sometimes you cause other problems. And so you like to minimize the amount that you do invasive surgery. So which is why we look to stuff like stem cells or PRP, or, you know, trying to harness like the power of the body as opposed to, you know, our power to fix stuff. So it's something that we're really interested in. I guess more of a background on me. I work with Synergy Orthopedics here in San Diego. We take care of the Legion, which is the professional rugby team, the San Diego Loyal, the soccer team, and then the San Diego Gulls, the AHL hockey team. So we get to take care of a lot of our awesome teams here in San Diego too, which is great.
That's super awesome.
Yeah.
I mean, did you play sports in high school or college or anything?
You know, I think I would impress no one with my sports resume. I played. I was wide receiver in let's see, like freshman and sophomore year at Bishop's High School, and I broke my clavicle and figured I'd stick to the books mostly after that.
Got it. Okay, so did you have any injuries in high school or anything that like kind of put you on that path?
So I broke my clavicle playing football.
Yep.
But honestly, it was more, so I ski patrolled for a year up at Kirkwood, and that's what really started driving me towards orthopedics. You know, the ability to see people who were, you know, just absolutely shredding, and then they were just sidelined completely, unable to do what they wanted to do. And we'd be scooping people up off the mountain left and right with torn ACLs. So that was the first thing. The thing that's really cool about orthopedics is by kind of laying hands on stuff, it's almost like a mystery. You have somebody who comes in with pain, and you're able to do an evaluation and do, you know, tests. We have different tests. So like for your knee, someone did a Lockman or an anterior drawer. And by saying, okay, this one's positive, this one's negative, we can come up with a diagnosis. And I just thought that idea was really cool within medicine.
Yeah.
There's a lot of specialties where you can do that, like neurology, neurosurgery, pulmonology. There's all these different things where by doing a physical exam maneuver, you can like solve a mystery, but none are quite like orthopedics in that way.
Yeah.
So it's pretty cool.
Gosh, it's such an interesting thing. Before I tore my ACL in high school playing football, I never had any injuries or anything like that. And, looking back on it, I wish the approach that we took was very different, because I think that the biggest reason why I probably still have some issues is because of the lack of like speed to like a solution, like a surgery or whatever. I think initially I tore my ACL partially, and at that point, what I really needed was like a reality check of like, hey, you're not going to play like in college or in the NFL.
Right.
Versus in what ended up happening though was, oh, like if you want to finish out the season or whatever, like we can throw a brace on you, which ended up just basically immobilizing my knee for the next 4 or 5 months. Then I lose all this muscle tissue and flexibility and all that kind of stuff. So it ended up not being the right approach in my opinion, but I'm curious, like when someone comes in and they say, hey, I think I tore my ACL or I did something to my knee and it's not resolving over the next day or two.
Right.
Like what approach do you take and what do you feel like the right approach is? And then what are some of the wrong approaches that happen?
Well, I think one of the things that's sort of interesting, and hopefully this will answer the question, but I think there's a lot of pressures within the healthcare system that force you to try and make a decision quickly. But I think one of the most important things is trying to figure out what are the symptoms that you're having and what are you aiming to try and achieve and what is this preventing you from achieving. So you have to kind of get to know the patient a little bit to know what the outcome is that both me as the doctor and you as the patient want to have. Because I think sometimes you can go in with the wrong approach. And sometimes you even have to have a hard conversation with someone like you're saying, where you have to say, okay, now realistically, if you don't wind up going on to play professional football, what are you going to do? What are your interests? And, would you sacrifice everything if you knew that you wouldn't be going on to play professional football?
Right.
Or should we also have a backup plan and be thinking maybe we don't play the rest of this season, we take the hit to have your surgery sooner, and compromise right now so that we invest in the future for you. So that's a conversation I have a lot. But so first of all, it's the physical exam, like we talked about, and getting to know the person. And then when you have a physical exam, like for you, like we said, the physical exam, making sure that your knee feels unstable or that there's something that we can identify that corresponds with what you're complaining about. Then you go on to the imaging and you can start to evaluate, what to do.
Yeah. Okay. So in a situation where like I'm pretty sure mine was partially torn, now are you doing surgery in a situation like that? Or is something like stem cells or PRP coming into play to see if you can like
cause it to heal? Or...
Yeah.
So I guess specific to your situation, ACLs are interesting because for me, it's sort of a ligament like an ACL is like a mechanical problem, right? It's an engineering problem where there's a structural support that you depend on in order to pivot. Or what position did you play in
So I played we ran this fly offense. So I played like a fly back, a receiver basically. But then I actually got injured on kickoff.
Okay.
I got this fucking blindsided by this dude, and my right leg was planted.
Which is the classic way that you tear your ACL.
Right. So yeah, it wasn't like a crazy violent hit where somebody ran into my knee with their head or anything like that. But
right. But one of the things that I see with people who play that kind of position is that when you're a receiver or you're a running back or someone who's having to make routes and make hard cuts, that even with a partially torn ACL, which we can kind of discuss what that means exactly, but you start to lose some of your ability to stabilize the knee when you want to do an aggressive cut.
Yeah, for sure.
And that's what makes a good football player. Someone who can make that sharp cut and lose somebody. So there are times where an MRI might not even be positive, but I can see some signs like there's some bruising on the knee.
Yeah.
Because the knee bruises when it pivots.
Right.
And if the knee pivots, you know that functionally, even if there's fibers of the ACL there, it's not functioning the way that it should. So there are times when I've gone completely against a radiologist who said an ACL was intact because I can see that the patient is totally unstable. They're not able to do what they want to do.
Yeah.
But the physical exam backs up what I'm seeing. And so we'll take them to the OR and scope the knee and see, in fact, the ACL may have been laying against the bone there, but it was totally disconnected.
Interesting.
And then sometimes you'll have somebody, who, there's also people who just bizarrely can compensate. They're able to, they might have an ACL injury that's partial, or maybe it's an insignificant ACL injury.
Mm-hmm.
So you have to be cognizant of how it's affecting a person's performance or their symptoms. So then I guess to your point, because the next question is, where does something like PRP or stem cells come in?
Well, yeah, because it's such a, for an 18-year-old kid or a 17-year-old kid, it's like such a, like, I don't know anything about anything.
Right.
Like you go see a doctor or a surgeon and you just assume, and I'm not saying that like surgeons have like a different agenda or anything like that. What I'm saying is you just have no idea what the fuck you're
Of course.
hearing.
Yep.
You don't even know, you have zero reference.
Yeah.
And so it kind of comes to this, like, where my interest lies is like, what could we have done? What should we have done? And then like looking into the future, hopefully somebody can listen to this and be like, oh, I tore my ACL, and they'll see this or whatever, and be like, oh, here's like some reference points of like how I should approach
Absolutely
getting better. And so to me, where I feel like things kind of went wrong and like maybe we could have handled differently would, I wish the doctor would have said, hey, like, looking into the future, you're probably not going to play, and you're like definitely not playing in the NFL.
Yeah.
You're probably not playing in college.
Right.
And like, we should approach it in a different way, because like what we ended up doing was like, well, let's put a brace on it. Let's see if you can like play the rest of the season.
Right.
Which I don't think was good for my long-term health of my knee.
Right.
Because what ended up happening is like got this custom brace,
Mm-hmm.
which kind of almost, in my opinion, now looking back on it, gave me like some sort of false confidence.
It's like a bionic leg all of a sudden.
Yeah. So like what happened was like, get this brace. Okay. Been out for like a month or like a couple weeks, get this brace, go to run a play. And I'm like, in my head, I'm like, oh, the brace is going to like do the job of the ACL.
Mm-hmm.
As soon as I plant on my right knee,
You pop.
yeah,
Mm-hmm.
like I can't, I just like literally fall.
Mm-hmm.
Like, and everyone's like, oh, fuck.
Mm-hmm.
So they move like the whole team to the other side of the field and continue on. And
Yeah.
I get fucking picked up and like taken to the sideline, and my dad comes and picks me up, and we're like,
Yeah.
this sucks.
Yeah.
So in that kind of situation, like, what can you do?
Well, I think the hard part about being a surgeon is that's a hard conversation to have. You're not going to play in the NFL.
For sure.
So sometimes I'll come about it sort of obliquely, right? I'll say, so what are some other things you might be doing to try and see if people have aspirations beyond, sports specifically?
Yeah.
Because, it's not necessarily, I think I will try and guide people gently through that.
Yeah.
But I'll tell you that I don't, like, especially, this was high school, right?
Yeah.
So in high school in particular, I'm pretty opposed to trying to let people, play through something that might cause them further harm.
Yeah.
And I think the challenge with your situation is that if your knee's kind of unstable, you have a risk of tearing a meniscus.
Well, that's exactly what happened.
Right. So which then causes bigger problems going forward.
Okay, so that's exactly what I was going to get into.
Yeah.
Is I feel like that second, because I'm pretty sure, like, looking back on it, like the initial hit, leg planted, kind of just like put my knee in a weird position where it just like either stretched it or
Yep.
partially tore it, and like no harm, no foul in a weird way.
Mm-hmm.
Like, I just get the ACL replaced, and then like everything should be relatively fine, because the meniscus is, to me, I don't know, I could be totally wrong, but meniscus is like something that you're dealing with every day. It's like this consistent. Or does the ACL come into play just me walking down the street, or is it when I'm trying to?
No, you're absolutely right. But there's two things about that. When we look at the literature on ACL tears, one of the biggest things that looks at your prognosis or your future symptoms is ACL tear with or without meniscus. So if there's a meniscus tear in addition to it, it tends to point towards a little bit more symptoms going forward.
Right.
Now, I've taken care of a ton of people who had meniscus tears in addition to ACL tears. They've done great. It's just, that's one of those things that, it shows a little bit more energy and a little higher severity of injury.
Yeah.
That plus cartilage, if you've had an injury to the cartilage, I think all of those things are things that we try to prevent, especially in somebody who's young and who's in high school.
Right.
I think it's funny because when you think about the meniscus, so basically, I guess to take a step back, the ACL functions to try and prevent your tibia from pivoting. So when you plant your foot
like
and
this?
you twist, exactly,
Okay.
rotationally.
Okay.
So when you planted your foot and you got hit, you probably spun and caused the tibia to rotate, which ruptured the ACL.
Got it.
So when that ACL is gone, you have these things, the menisci. So you have one on the inside and one on the outside of your knee.
Yep.
And they're the secondary stabilizers. So when the ACL is gone, they pick up the slack from the ACL to stabilize that rotational motion. So that's why you oftentimes will see a meniscus tear after an ACL has been treated non-operatively. So that's something we know, like that's a natural history course.
Yeah.
We expect that kind of thing to happen.
Yeah.
So, if I knew somebody had an ACL tear a long time ago, and they're like, now I got some pain on the inside of my knee, without even doing a physical exam, without, just from that history alone, because we're talking about, you start off with the history, and then you go to the physical exam, and then you go to the imaging.
Yep.
It's step one. I already have a suspicion that they have a medial meniscus tear because of that natural progression after an ACL tear.
Yeah, man. Thinking back on it, it's like, geez, I wish that was somebody, like there was I just don't remember like the doctor explaining like what could happen if
Totally,
like how that could affect me later on in life.
Right.
And I think it was more just like I'm sure I wasn't very receptive.
That's one of those.
But I wish, I don't know, I would have been pissed if the doctor was like, dude,
yeah,
like let's just deal with it now rather than like potentially hurt you even worse.
Right.
But being 17 and like,
I think that's the hard part too, is talking with a 17-year-old about how their future, they should protect their future, and that tomorrow's game isn't the most important thing in the world. It's a harder sell to make.
Yeah, for sure.
But also, I think that our appreciation of the importance of the meniscus has changed a lot, because back in the day, we used to do, basically they thought of it as like the appendix of the knee, right? You could just cut it out and there'd be no symptoms.
And it's far from that.
It's far from that.
Yeah.
Now we find that there seems to be a higher rate of arthritis if you cut out the meniscus completely. So we try and suture up as much of it as we can.
Mm-hmm.
And sometimes as you get older, like if I tore my meniscus today, I wouldn't be that worried as, an almost 40-year-old having my meniscus partially resected. That wouldn't be that big of a deal. But for a 17-year-old, that's not something you want to do.
Right. Okay, so surgery is kind of like you have to do it. Like you have to use surgery to repair. Now, looking into some new technology that's coming out, stem cells. And okay, can you explain the difference? Is stem cells and PRP the same thing, or are they different
They're
things?
different.
Okay.
So I think overall you have this category of what are called like biologics, right? So there's something that are generally taken either from you or cultured or something like that. But it's not like a pharmaceutical type of a thing, like a steroid or a medication that you inject.
Got it.
So PRP, what we do is we'll draw blood, venous blood, and then we can spin it. And so the blood typically carries oxygen through red blood cells. And by spinning it really fast, the red blood cells are heavier, so they sink to the bottom. And you have the fluid that the red blood cells are sitting in,
Right.
which is the platelet-rich plasma.
Okay.
So we take that off and we can inject it. And that doesn't have, we're not looking at cells to regrow things with that, but we're taking advantage of some of the signaling mechanisms within your blood to try and heal and decrease inflammation, or sometimes increase healing through that PRP. And we can we have some tricks to sort of manipulate how that PRP is made to see if there's more healing potential or more anti-inflammatory potential. But the goal is not to, put in new building blocks to try and create something.
Right.
Now, when you talk about stem cells, the purpose of stem cells, like the definition of a stem cell, is something that duplicates and goes into two different things, right? So let's say you start off with A and it divides into two different cells, and you get one of A and two and one of a different cell that's going to be further down the lineage. So like basically it replicates itself once, but then it makes any number of other different types of cells. So let's say we're talking about ACL, or more importantly in orthopedics, cartilage, right? Okay. So you have a stem cell, so like a mesenchymal. We don't have to get too deep into the doctorese with it, but the one stem cell could go into a cartilage molecule or something that would create a cartilage molecule, and then another stem cell. So that's been very elusive. It's hard to find. And the goal is to try and put those, it's basically a building block for whatever, all parts of the body.
So you can get stem cells from whatever, anything, right?
We all develop from stem cells, right? So like when, like the embryo is just basically exclusively stem cells.
Right.
Through our development, there's all these different lines of stem cells that go on to be muscle, cartilage, bone, tendon, all these different things. And that's the way that.
So where are they harvesting stem cells from?
So that's the challenging part. Is there's some that are coming from like you can get some from fat, you can get some from bone marrow, but most people when they're selling stem cells now, there's like the FDA restrictions are pretty tight on stem cells. So most people are using fat-derived stem cells. There are also some, which would be like, okay, there's types of stem cells that we take from you. So, right, we'll draw off from you, and then we'll prepare them, like, right there in the operating room or wherever.
Oh, really?
There's other types of stem cells which are from somebody else. So they're like a donor tissue that has been prepared. And those are, I think you have to be careful about how you describe them, because the cell content, what I had described about building blocks for trying to recreate cartilage or whatever, regrow from those specific cells, it's so far it's been hard to actually get the cells to survive. So most of the impact has actually been from signaling molecules that come off of the cells.
Yeah.
So we talk about paracrine signaling cells, so which basically like the cell gives off signals to things around to help with healing.
Gotcha. Gosh. Okay, so that's the magic is
that's the golden goose.
The signaling.
Mm-hmm. Well, yes, that's what seems to be happening right now with what we have access to.
Got it. Okay, so to paint a picture, you pull cell, like if I like come in, I'm like, hey, I want to get stem cells, but I want it from myself. What's going on?
So I guess I don't do a lot of things that we call stem cells. Most of the time what I'll do, like kind of the biologic that is closest to that would be bone marrow aspirate concentrate. So basically you make a little incision along the side of your hip, and you take you make a little hole in the bone on the side, and you pull some of the fluid out from the bone. And so just trying to describe that in the least graphic, offensive way possible. But basically you pull off a little bit of that, the cells from in there, and then you spin it down to try and get the most biologically active portion of it. So that bone marrow aspirate concentrate, you can then inject. And it's like, I think whether or not it's actually true stem cells, the signaling molecules are more meaningful from there.
Right. Okay.
Versus the PRP, we'd have you come in and we draw blood,
spin it, and then re-inject it into the site, like where you. Okay. Wow.
Yeah.
Have you seen like or what's the situation with like, say you were to drill into my hip, pull some fluid out, prepare it, inject it into my knee, try to target, I don't know, do you do like multiple injection sites or you do?
Like I guess the most effective thing that I've seen it for, so the knee, I guess describing the knee is sort of, it's a fluid-filled space. So when you talk about like the ACL, the meniscus, the cartilage within the knee, they're bathed in the fluid, in the synovial fluid of the knee.
Right.
Versus something like your MCL, which is along the side of your knee, that's sitting in tissue.
Right.
So if you inject something like PRP or stem cells into it, it's held right up against the MCL, and so it can heal a little bit better. And so I'll oftentimes do MCL injections or patella tendon injections, or sometimes for the elbow, you can get like tennis elbow or golfer's elbow, you can inject those with PRP or something that's a biologic to help facilitate healing.
Right.
For the ACL, for the same reasons we talked about, that's under tension. So it's sort of like, it's a structural piece. So we want to reconstruct it to try and give it the best, possible chance of stabilizing the knee and protecting the meniscus for the future. Although there's been some advances in ACL repair. So if you pulled your ACL directly off of the bone, there's a new technique where we inject blood directly into like this is going to be sort of...
you can get graphic.
Well, no, it's just this isn't going to be an appropriate full description. Basically, you have a sponge that you stick into the knee and you sew into the ACL and you fill it up with blood, and then you repair that in between the ACL and the bone to help facilitate healing. So you just have it's just blood that's in there, and it helps.
Like a bridge to the bone?
A bridge, exactly.
And then the ACL like fills back in?
Mm-hmm. Yeah.
Whoa.
So, and I think there's been some mixed results. It's a higher failure rate, but it's kind of cool if you can keep your own tissue.
What's the gold standard at this point for
ACL reconstruction?
Okay, which is...
So my favorite, and especially for like young athletes or professional athletes, I'll take a piece of the patella tendon, piece of the patella, and a piece of the tibial bone. So it's called a BTB, and then we do just basically we'll drill through the tibia, we'll drill through the femur, and then we'll position the graft in between, fixating both on the tibia and the femur.
That's what I had.
Yeah.
Yeah.
So, and I think there's problems that come along with that, but has your ACL remained intact?
I haven't had a situation where I feel like I tore it again.
Yeah.
I don't know. Maybe you could do the little
Yeah,
pull
you do the
test
little
or
Lockman, exactly.
whatever.
I'll check you out.
I think I think at this point it's some like there's some scar tissue and some like muscle stuff that was never addressed.
Yeah.
And like flexibility.
Totally. But you probably have. Do you have a little bit of pain in the front of your knee?
Not too bad. And to be honest, like when I start warming, like running or whatever, exercising, like, and things kind of start to get warmed up and like the fluid I think starts circulating or whatever's going on, then everything starts to seem kind of like okay.
Yeah. And
I've done drills with Marcus where we're like moving laterally and nothing's ever failed.
Right.
And I actually went to Marcus because I had like this kind of sharp pain on the inside of my knee when I would run. Like I was having some trouble running, like with the pain, and he was like, "Oh, roll it out," and it was like it ended up taking care of it because I think that one of my the muscles like on the inside of my leg was like pulling on something.
Yeah.
And so as soon as we like worked that out, then I was like, "Oh, it feels totally fine."
Yeah, you bring up a good point there because not to point out our own weaknesses, but we have blinders on as surgeons, and that's the beauty of someone like Marcus who's able to he can through like manipulation or targeted exercises or something deal with things, whereas we tend to be like, oh, you need surgery for this.
Right.
You know what I mean?
Yeah.
I often find myself telling patients that I've had to teach myself how not to operate because I spent 5 years of residency and a year of fellowship learning how to operate.
Right.
And then it's taken practice to learn how not to operate.
Right.
So I think someone like Marcus is really valuable for something like that.
Yeah.
And our athletic trainers and the physical therapists who come alongside and work on stuff, because then your knee feels good afterwards, right?
Yeah, and I think a lot of to me, my biggest issue, and I'm guessing this is common for a lot of people, is like being immobile for however long before surgery, and then obviously you start rehab after.
Yeah.
But you might not start it for like, I mean, I guess probably nowadays people are like pretty quick to jump into rehab, right? Like how quickly are people?
It depends a little bit on the nature of the injury. Like I did 2 ACL reconstructions yesterday, and one of them had a big meniscus tear, and so I'll be slower with that one. And versus, one that just had an ACL reconstruction, I'll be a little bit more quick with. But typically it's within 2 weeks or so.
Yeah. So yeah, I guess looking back, it's like I feel like my situation was like because I was immobile for probably 2 to 3 months beforehand, and I just basically had it in a brace. Like I experienced a lot of atrophy in the muscles.
Absolutely.
And then going like versus like some NFL players who have ACL issue, like they tear an ACL, but like nothing else was touched, like no meniscus, those guys are like top athletes and they're fully in shape and they get surgery that night.
Yeah.
And then they're in rehab 2 days later. And it's like, they end up playing, 8 months later.
Right.
And it's just, now I'm like, God, man, I wish I would have just like got the surgery, whatever.
Yeah.
It's such an interesting thing because I feel like so many people prolong addressing the problem.
Totally.
And nowadays, like, I think the stem cell thing and PRP and all that stuff is like super helpful, but I also feel like a lot of people think it's like it's the instant fix.
Right. It's like the platinum pill or something that's going to fix everything. No, I think you bring up a good point, because I think honestly that's sort of the type of medicine that I would aspire to, is being able to provide that kind of care. Because if we look at our professional athletes for our teams, they have rehab kind of around the clock.
Yeah.
And ultimately, really, you should be thinking about yourself as a professional athlete in rehab after an ACL reconstruction, because you only get one opportunity to rehab it, the right way and do the right thing. So, and I think it's hard also to convince yourself that you definitely need to go for surgery sometimes. And, I have lots of people who will show up a couple months afterwards when they've already done some damage or they've just been busy or whatever. And I do feel like there's a risk of injuring yourself more with that.
100%. Yeah. What do you do when somebody, like, say you do a patella replacement and then 2 years later they tear that?
Well, first off, start by feeling really bad about it, because
it's not your fault or anything.
No, but it's kind of funny. This is something that's also been interesting as I've grown as a surgeon. Is like every person who I operate on, I am invested in fully.
Right.
They're like I feel like I want to know them, so I know who and what I'm operating on and what I'm trying to achieve for them. You know what I mean, or with them.
Right.
And so, you just sort of feel for that. But then if it does tear, the first thing I try and figure out is why, right? Because, if you do a good job of this, there's a pretty low incidence of re-tear.
Right.
Right. So like, depending on the situation, it's, less than 10%. So if it tears again, you need to sort of check. In general, I would know I had done a good job. I have a pretty consistent ACL reconstruction technique because I do a lot of them. Mm-hmm. But sometimes if you might miss something like different anatomy, where someone has if their tibia, the top of their tibia is sloped backwards a little bit more, it puts more strain on the tibia or on the ACL, or some different types of alignment, or so that the first thing I would be looking at is why did it tear? And sometimes it's just you got tackled, or whatever, a barrel clamped down on you or something like that.
Yeah.
And you can't fix that. But if there's something that I could potentially fix, whether it be the alignment or some other anatomic piece that contributed to the re-tear, then I'd try and identify that first. And then, I guess you talk with them about what the expectation is, see how impacted they are by the ACL re-tearing. and then try and figure out a plan, which probably involves revision ACL reconstruction.
Okay, so what is that like? Do you start to take like some tendon from the hamstring area, or
you have a bunch of options?
Okay.
Like, so I guess if we talk about grafts, there's two different types of grafts for ACL reconstruction. There's auto, which means taken from you, and there's allo, which means taken from a cadaver, typically. So my favorite grafts to take for auto, and for, most of my patients are somewhere between the age of 15 and 50 or something. And so for a lot of the younger end of that spectrum, autograft is the best choice. And so I'll take either BTB, which is the patella tendon, or I'll take the quadriceps tendon, which is right above the kneecap.
Okay.
You can take a little segment of that. So if someone fails at the BTB, sometimes I'll take the quadriceps tendon without taking any of the bone, just take the tendon itself.
So you just slice out a little piece?
Yeah, a little, like about a centimeter thick. It's a small portion of the quadriceps tendon.
And then what, you sew that back together?
Sew it back together, and it heals beautifully.
And then they don't know any different from that?
No, the knee functions just fine.
Yeah.
But you're able to do a great reconstruction with that too.
Interesting.
So and it doesn't wind up being too terribly challenging to do the revision.
Yeah.
Not that much more than doing a standard one.
Yeah.
It's just more trying to figure out why it happened. That's where sort of the challenge comes.
Is it as simple as sometimes just you just wasn't able to handle the force that you were?
Yeah, but then sometimes you'll think about there's other procedures that you can do where you augment some of the ligaments on the outside of the knee. There's something called a lateral extraarticular tenodesis, where we take a little bit of your IT band and we route it along the side of your knee, and that's like a backup. That was it's funny because there's a lot of old techniques that we're revisiting, because that used to be the way that people did ACL reconstructions.
Whoa. Okay, so wait, explain that one.
So like I was telling you, that the ACL restrains your tibia from twisting. Right? So back before we had access to good arthroscopy, and you had to do a big open knee procedure where you'd make, a 10 centimeter or 10 inch incision or something like that to open up the whole knee to do an ACL reconstruction. That was a ton of downtime, a ton of complications associated with it.
Yeah.
And so people didn't do ACL reconstructions as much. And so as people were trying to figure out how do you fix it, then they did something called a modified Lemaire technique, or a lateral extraarticular tenodesis, where you take a little strip of the central portion of the IT band, which attaches down to your tibia, and you route it up to your femur, and it prevents the tibia. It's like a check rein along the outside of your knee to prevent your tibia from rotating like this.
Holy shit.
So you can back up an ACL reconstruction using that. And sometimes I'll do that if I have someone who I'm really worried about.
Yeah.
Or who's had a re-rupture of an ACL reconstruction.
That's crazy.
Yeah.
That is
cool
so
stuff.
wild.
Yeah.
Oh man. It's such an interesting, because do you ever find people that have a torn ACL and it was just like a total fluke thing? They're not very, into athletics.
Yeah.
And they're just like, do I need to really repair it? Do I need to go through surgery?
Absolutely.
It just kind of like, okay, yeah, you did tear it, but you don't play sports and you don't ski and you don't surf and you don't play tennis. You could literally live life without an ACL, right?
You could. You absolutely could. And I think probably, I don't know. I think we're so capable of doing ACL reconstructions nowadays that there are some people who probably would do just fine, who we do ACL reconstructions on. But in general, I'd say most of those people come telling me they don't want surgery. They're like, Doc, listen, I know I probably did something. I don't really want an ACL reconstruction because my knee feels actually okay. Yeah. And that's there's a portion of people who, for whatever reason, are totally capable of compensating for their ACL instability. Right. So, they're able to run, or maybe, even if you were a runner and let's say you're a marathon runner, you just want to run straight in line. Yeah. It's the pivoting and the cutting that tends to be the problem. Right. Now, if you're able to, and some of that has to do with like the stuff that you were talking about with Marcus getting stronger around the knee, stabilizing knee in that way.
Yeah.
That stuff can help so you don't depend as much on either the meniscus or the ACL for stability. So, yeah, I think there's all sorts of different, I mean, and that's where it comes in getting to know your patients and who you're operating on, because there are people who just have no interest in going through that, and it does not benefit them to go through that year of being a professional rehab athlete, you know?
Yeah. Man, it's a trip. It's a weird thing. I did the ACL on my right knee, and then like it's probably 3 years after that, I was skiing, and I was like skiing in the park. I hit a rail, and it was the end of the day, and we'd been boozing a little bit, and I just like slipped out, and I ended up fucking chipping my kneecap on my left. So I like chipped the top part that had some of the quadricep tendon.
Yeah.
And so now I have like this little loosey-goosey piece of quadricep tendon. And it was the doctor basically like removed the piece of bone and then like stitched it back.
Yeah.
But I think that rips back open at some point.
Yeah. Although the quadriceps is pretty good at healing. So
yeah, maybe it
that,
did kind of pull it. I don't know.
Yeah. The funny thing, though, you're talking about the end of the day, and then you're asking about people who weren't that athletic, or it was inconsequential. It wasn't like a football maneuver.
Right.
I would say the majority of my ski ACL tears are not someone hucking a backflip off of a cliff. It's someone traversing a catwalk at the end of the day when they're
lazy.
Last run. You know, just a lazy, like a little pit, because of what the ACL does. It prevents against pivoting.
Yeah.
You get a little tired, a little whatever. And so I think that's the reason that you have a lot of, you know, weekend warriors like me who are tearing their ACL because they're not keeping up and not, you know, staying strong with their stabilizers. So
how it's so important if you are, you know, out of college or whatever, out of high school, out of college, you're not a professional athlete, but you are still very active. It's so important to maintain strength and mobility in your legs, around your knees, shoulders. Shoulders are probably a big one that you do. Yeah.
Huge.
Yeah.
And I think one of the things that's most interesting is it's not, you know, you think about working out and you know, we get images of like weightlifters getting huge, lifting a ton of weight. It's oftentimes not, you know, a lot of weight. It's the repetitions and just, you know, like when I want someone to work on their shoulder strength, it's band exercises at low weight with high repetition to try and activate their rotator cuff muscles.
Yeah.
Or trying to keep your hip stabilizers, your hip abductors strong just by doing stuff like, you know, pushing out with your foot against a band to flex your hip.
Yeah.
And just little things like that. And stuff you could do over the course of maybe 10 or 15 minutes every day.
At home.
Just minimize your chance of injury. And obviously, you know, if you have like the one-off injury where something traumatic, you're still going to be injured. But for most of the injuries that are just a simple, I tripped and fell, I, you know, twisted wrong, or, you know, I went to grab something and my shoulder popped.
Yeah.
You know, a lot of those things can be prevented by just simple, you know, good practices like stretching and strengthening like that.
Yeah, it's crazy. Ever since I started working out with Marcus and, you know, I like playing football, it's so much about like how much can you squat, how much can you bench press, all that kind of shit. And like we never did any of the preventative stuff, which, you know, I don't think most football programs are doing. It's more just like how much can you bench at the combine, or whatever your stats are that you need to get drafted.
Right.
I just don't, like, so many people don't talk about, like, you see all these like fitness people online and, you know, weightlifting experts and stuff, but none of them talk about the small, like, technical, like, preventative exercises. Like, starting to go work out with Marcus was like eye-opening. Do you work out with him at all?
No, but I've met him and he seems awesome.
I mean,
David raves about him.
Yeah, I've worked out with David a couple times with Marcus, and I haven't recently, but, you know, for a couple of years before I was working out with Marcus, and like he has all these crazy off the wall things. You're like, why the hell am I doing this? And then 2-3 days later, you're mountain biking and you're like, oh my God, I feel so much more stable.
Yeah.
Or like whenever, like when the effects start to kick in of like the exercises you were doing,
Right.
or if you're just running, like I'll go trail run and I'm like, geez, I feel like my legs are lighter.
Right.
And it's just because you're doing like weird exercises that you don't think of. It's really interesting. I wish more people would talk about that kind of stuff. Totally. Do you have, so you work with some athletic teams, do you have conversations with the athletes
So that has become a much bigger part of the training regimen for those guys. So they have it dialed. They do all of that stuff. And increasingly there's like exercise regimens with like youth soccer players to try and prevent ACL tears.
Yeah.
FIFA has come up with a whole like, set of things to try and strengthen your hips, to work on your quadriceps, your hamstrings, make sure that you're capable of supporting the type of activity that's required by soccer first before you start playing it. And all those things are huge advantages. But I think one of the things, it's sort of funny, I mean, like the type of stuff that you're talking about where it's just day to day, it's not how much can you bench. It's sort of like the health equivalent of eating right, which is sort of like the least sexy thing to talk about. Everybody wants to talk about like the really intense thing that they did or whatever.
Yeah.
But it's the day to day that's going to have the biggest impact on your health.
Dude, 1,000%. I couldn't agree more. I think like recently I've had these 2 months that I was down in Cabo awaiting our baby. And, the month leading up is like my wife's still, finishing up some work and stuff. So I have like some time to like just go run or whatever.
Right.
And I got on this really good program of like running about like 3 miles, like every day, if not every day, at least every other day.
Right.
And like after a month of doing that, I'm like, holy shit, I just feel so much better. And I would take a band and I would like, stretch out like this and then front and like behind. And then I would like kind of stretch it over my head and like go down to the back and just like opening up my chest and everything.
Right.
Doesn't really feel all that great the next day, but like after a month of doing it, you're like, holy shit.
It's those daily investments that you make
in
personal health that are so important. The other thing that it makes me think of, because in med school we don't get taught a lot about the alternative type treatment ways, like so physical therapy. We send people to physical therapy, but learning more about like what exactly they're doing but then even further off of the typical medicine type of treatment algorithms is like yoga and Pilates and acupuncture and all these different things that like I've seen more people with horrendous back arthritis and whatever do great because of just daily yoga for core strength. And it's made me into such a believer in that. I think it's so huge. Yeah. And it's just the daily routine of the stretching, the strengthening, and the being diligent about kind of taking care of yourself that makes such a big impact.
So true. And I always like, I'm on fucking Instagram and I'll be like looking at people, doctor, carnivore guy, and then like the dental guy, like talking about how, one person's talking about how much diet affects everything.
Yep.
Right? Like everything. And then this other guy is talking about your breathing and how breathing through your nose can like really, and now he just started revealing some evidence of like breathing through your mouth that the majority of the time can have an effect on like how your jaw develops, which then potentially can affect how your spine looks.
Yeah.
And I'm just like, holy shit, like we've gotten so far away from that kind of stuff that it's just, which kind of brings me to this question of like, so you're professionally trained, go to medical school, like, okay, so what's the exact like path to becoming a surgeon? So undergrad.
Do undergrad for 4 years, and then you go to med school for 4 years.
Okay.
And then 5 years for orthopedic surgery, which is what I do.
Yep.
There's 5 years of orthopedics, and then there's an additional year of fellowship if you subspecialize.
Okay.
So like to be able to do, sports medicine surgery and really focus in it and kind of become an expert in that field, that's how you do it.
So at any point are you being taught like, okay, yeah, you're going to be an orthopedic surgeon, but like, here's how diet plays into it? Or is the diet stuff something that you've just got interested in after?
I think it's, I think when you meet people and you start to take care of people, you realize that there's so much more to it than just the surgery.
Yeah.
And that's really where your interest gets drawn into it. I think, we're taught along the way, but it's sort of like trying to tell a 17-year-old that he's not going to play in the NFL.
Right.
Like, you have to be in the right place with the right mindset in order to be receptive of that.
Yeah.
And as in, it's hard to imagine, but even, as a medical student or an orthopedic resident, you're so focused on just honing your skills of becoming a surgeon or whatever you're going to be doing.
Yeah.
That it almost is sort of like an afterthought to present some of that stuff. And I think they do a good job early on in med school about talking about some of that stuff. But you have to sort of incorporate it. It has to be sort of meshed together and sort of made your own plan for, okay, how do I advise someone about, I don't do a lot of dietary advice, but people will always talk to me about dieting and there's this and there's that. And so I try and keep up a little bit on it. And,
yeah.
So I think you constantly have to be learning as a physician.
Yeah.
If you're going to provide good care.
Yeah. Yeah. Oh man. Really, really interesting stuff. I get so just consumed with like all the new research and stuff. Cause like when we first, met and kind of like your brother told me that you were a surgeon, I was like, oh shit, I have so many questions. And like, I guess really, unless like, somebody like how I know you, the only real access to talking to a surgeon is if like you tear something and then like you talk. I mean, how many people are actually sitting down with the surgeon and talking to him about these? It's not like the most common thing to do, but I think it's so cool to like be able to sit down and ask the questions of like the normal person that maybe had an ACL injury 15 years ago.
Right.
Okay. So which brings me to my next question of like, so when you perform a surgery and you prescribe rehab or PT, like how receptive are people to like the commitment that they need to? Are people just like, okay, yeah, whatever. It's like just kind of.
I think it's as different as people are themselves. I have people who are so committed that they buy into the rehab afterwards, like we've been talking about. Like I have a guy who came in the other day who has continued to go to physical therapy periodically just to keep up on the stuff like the shoulder strengthening and the knee exercises and the whatever. And then I've also had people who are, completely unreceptive to it. They didn't listen to a thing that I said. Like you talked about quadriceps. I've had people who had quadriceps ruptures where they just, I had to repair it and then they threw away the brace and they came in literally mid smoking, like all the things that I had told them not to do. And so it runs the whole spectrum, but I'd say most people are very receptive to it.
Yeah.
And I think that's our duty, right? Because if I do a surgery on you and I know that you're not going to do the rehab that's appropriate to get you to the right endpoint that we both want for you, then I've failed you, right? It's like I was talking with Dave this morning, and you're in this situation.
Yeah.
It's like I read a statistic somewhere that said 90% of infant car seats are installed incorrectly, and I was like, okay, what that tells me is that they are made incorrectly. They are designed poorly because 90% of people, at least 40% of people should be able to figure out how to do that. You know what I mean?
It's pretty straightforward.
It's pretty straightforward. But if you have a failure rate that's high, you have to think about like, what am I doing to contribute to that? And so with orthopedics, I think a lot of it is about talking to people ahead of time and just really getting them to buy into what's required to have this be a good outcome, because everybody wants a good outcome for the most part.
I mean, it's such an important part of like happiness to me. I feel like not committing to it is like that's just a way to become unhappy, because if you always have this nagging issue, because you can get like, if you get surgery like that like fixes the problem acutely, but it doesn't necessarily make you have to work at getting your leg or your knee or your shoulder back to as close to normal as possible.
Absolutely.
Like you can't just do ACL surgery and then like everything's all good.
Right.
So,
and I think part of it too is it's not just an endpoint thing, right? Like when you get ACL reconstruction, it's not like you're just done.
Yeah.
The process of getting there is as important. It's like training for a marathon.
Yeah.
So much of that experience is about the training that you went through for months in trying to get to that point.
Yeah.
It's not finishing the race. It's kind of the build up to it. So there's a growth potential and like a strengthening, personal strengthening potential that comes from ACL rehab reconstruction, dealing with the ups and the downs and the whatever.
Yeah.
It's a big journey. So getting people prepped for that journey is so critical for their success long term. Yeah,
that's a good point. The psychology of going through surgery and then like life after surgery, I guess.
Yeah.
Like it's been, since I was 18, I'm 35 now. So, 17 years. And it's now I'm like, I should probably like really focus and address this thing that I've been living with for 15 years or 17 years. Like it's never felt the same, but I feel like there's potential that I could get it very, very close to being 100% or 90, 95%. Like I would say it's probably like 80%.
Right.
But like, I can start to bend my knee in certain ways and I'm like, ooh, it's not as flexible as my left knee or whatever. And I think when it comes to like your overall like holistic health, you have to address those certain things. Like you have to address your diet, you have to address your cardio, you have to address everything to get to that 100% or at least as close as possible to it. And so, I guess my like goal was to figure out, kind of just like the ins and outs of like going through surgery and stuff, what kind of options there are for people, stem cells, PRP, that kind of stuff. Have you ever seen like torn meniscus or torn labrums be completely healed without surgery using stem cells or PRP? Because there's people out there on the internet claiming that it can.
So the challenge with the reason I'm laughing is I had a patient recently who I prepped for a big surgery for a meniscus repair, and I went in to go do the surgery, and the meniscus had totally healed itself. And it was a relatively short period of time. So I don't know if maybe the MRI was wrong or what exactly it was, but it looked like there was new healing tissue.
Like you actually went in?
I went to, he had an ACL tear too. So I reconstructed the ACL. So, but, that doesn't happen a lot. And part of the reason is there were some really good studies that were done back in it was in the 80s where they injected some dye into the blood vessels that feed the meniscus. And then they took slides of them, say sliced up the meniscus because the dye was nice and dark and you could see where it got to.
Right.
And the blood flow only goes to the outer third of the meniscus. And the rest of the meniscus is just bathed in the synovial fluid. So the ability of the meniscus to heal itself when you have a tear of certain portions of it is relatively limited.
Right.
Now, that doesn't stop a lot of us from trying to repair it because cutting it out doesn't necessarily make it that much better.
Right.
And so we try and do different things, whether you try and facilitate more blood flow where you can kind of fenestrate it or basically make channels in the meniscus to try and bring blood flow more centrally into those areas that don't typically have blood flow, or injecting PRP or bone marrow aspirate concentrate or different things like that. And I've definitely done repairs on people where I came back and found that something that I didn't expect was going to heal very well, but it was sort of a Hail Mary because they're a running back or they're somebody who I really want to have, I want everybody to have the best possible outcome, but that I feel like their career might take a pretty big hit if we weren't able to get that portion of the meniscus repaired. You come back to address something else and you'll take a second look at the meniscus and it's healed. So I think in spite of all of those studies, there's more to it than we realize.
Yeah.
And that's the case with all of orthopedics, which is what makes it exciting to continue to be a part of it because you have stuff like stem cells. You have, there's things where there are companies that are 3D printing collagen matrix for meniscus repairs, where you can transplant, something and then inject some either stem cells or something that helps to facilitate cells coming in to regrow your own meniscus. We're not there yet. It's not, I couldn't offer this to you tomorrow.
Right.
But the growth potential is so huge for the future.
Yeah, so that's kind of like I was getting. So there's like the traditional, like you tear your or your meniscus, you can carve it out.
Right.
That's kind of like old school stuff, right? And then, or like to sew it back together.
And then there's minimal resection, which is what a lot of meniscus tears wind up requiring.
Yeah.
Like I don't want to say that all meniscus resection is old school, because I would say a good percentage, probably at least 50% plus of the meniscus tears that I address just wind up needing to be cut out because they're small, and the rehab and the consequences of repairing it would be worse than the consequences of to just cut it out and stop it from flipping into the joint.
Yeah,
but
that kind of feels weird.
It feels really bad. Yes.
So there's like all these. So as we start to move into like, okay, so maybe you can, I don't know, I guess put those little channels in there to try to increase blood flow.
Yep.
So that's one part, and then stem cells, PRP potentially, but then there's this thing of essentially growing a meniscus in a petri dish, and then being able to somehow replace it or insert that. What is the like full on like artificial, like is there an ability, do you have the ability to artificially replace meniscus with like just like whatever specific type of plastic?
Not yet. There have been a couple attempts at it, but I don't think it's come to market yet. What we do sometimes, what I'll have to do is I had a patient who outside the U.S. had a surgery where basically it wasn't done exactly the way that we would typically do it in the U.S. and they wound up cutting out the entirety of the meniscus. And he was young, and so I wound up revising some of the surgery. But the meniscus is completely gone at that point in time.
Yeah.
And so for this particular individual, I wound up doing what's called a meniscus transplant, where you can take a meniscus from a cadaver, and you can transplant it into the patient to try and give them that shock absorber, that stabilizing effect. And what you do is you'll take a channel of bone that's connected to both the front part and the back part of the meniscus, and you just slot it in, sort of like a tongue and groove type thing. And I mean, a lot of orthopedics is like woodworking. So you do kind of a tongue and groove fit into the tibia, and then you sew it in. And he's done really well with that. So
that's fucking crazy.
Yeah.
Yeah, I'm always get tripped out. Like I'll sometimes watch like surgeries and shit on YouTube, and I just like the first time you ever performed a surgery or like being taught how to do surgery, were you like, wait, what? I gotta like use that much force, or like that's trippy, right?
It is, and what I'll tell you is the craziest part. The force is very real.
Yeah.
The most, I think, we talk about like in experience. If you think about memories or whatever, so many things are triggered by smell, right?
Oh.
So you can be brought right back to like, I don't know, a trip you were on, a first date, or whatever. But it's really, really powerful when it comes to fear and things that you feel, are not right. So when there's certain smells that are in the OR, you use to stop bleeding, you'll use what's called an electrocautery, and it gives off a little bit of smoke, and it's a very strong smell. Or like if you replace a knee, you can do a knee replacement if you have bad arthritis, where you replace the surface of the femur and the surface of the tibia, and you cement it in, and that's got a really strong smell of cement.
Like actual cement?
Yeah, I mean it's like a biologically appropriate cement, but you cement it into place so that the person can get up and walk the next day.
Yeah.
And the metal or the plastic is cemented into place. So those smells, I can't tell you the number of people in my med school class who went on to be successful surgeons who fainted at their first surgery at the smell of the electrocautery, or sometimes it's the force required to put in an orthopedic implant or something.
Yeah, dude. I always think about that because that's not something that's like very like public information. I don't know. I always think about it. Like, so the first time you ever, so they're teaching you how to do surgery. I'm assuming you're watching like a a surgeon who's done it for whatever 20 years or something, you're watching. At what point are they like, okay, here's the tools, like go for it?
I will tell you that it's way later than you feel like you deserve. You feel oftentimes like you deserve to be
doing the thing
earlier than they'll let you, which is what everybody in the general public wants to hear. But yeah, I mean, you spend a lot of time proving yourself.
Okay.
Right? And it's like, it's kind of, it's an old type system where you kind of have to just be there. You show up, yes sir, whatever, you're holding, we say it's holding hook, but basically you're retracting, which is you're pulling the wound open so that the surgeon can see better as you, and as you demonstrate yourself. And meanwhile, the guy's asking you hard questions about the surgery to try and prove whether or not you prepared for it appropriately.
Right.
And so then at some point in time, once they have enough confidence in your answers, they might let you start off by just being able to close the wound, right? So like with a knee replacement, you're mostly retracting, and then at the end they might be like, here, why don't you put in this layer? And then most surgeons who are teaching they're good at criticizing and giving feedback on things. And so by the time you're actually doing something, you feel very, very confident in what
so it just starts out slowly, kind of like anything. It's like, okay, you can put the bolts back on.
Exactly. Exactly. Yeah.
That must have been a pretty surreal experience the first time you did a solo surgery, right?
Yeah, I'll tell you. So
it's like the first time driving after you get your license.
my experience was particularly surreal though, because the year after residency, my wife and I moved to Kenya for a year.
Okay, so your brother mentioned this, and I was
So we moved to Kenya for a year, and it's a long story, but basically, I thought we were just going to go to Kenya for a month and then move to Zimbabwe to this hospital. And they said that there was no room for me. They had all the orthopedic surgeons at the hospital we were going to visit in Kenya. And so I was like, okay, cool. It's going to be chill. I'm going to hang out in Kenya for a little bit, walk around, maybe meet some of the orthopedic surgeons. So we flown like 15 hours from LAX to Dubai down to Nairobi. And then it's a 4-hour drive from Nairobi out to this rural hospital that we're going to. And we show up, I'm like, this is going to be great. And I'm met by one of the orthopedic surgeons. And since I had this conversation, like at least one or two of the orthopedic surgeons had family things that came up, and they had to leave.
Right.
So it's just, I basically am joining two other guys who are totally swamped. And the guy comes down breathless, and he's like, oh my gosh, so thank goodness you're here. Are you ready to start operating tomorrow morning? We've got a full room for you. And I'm like, well, I'm fresh out of residency. And of course, I was doing a lot of cases basically on my own at the end of residency. But he said, there's this guy had been trampled by an elephant or something.
Oh, Jesus.
And so he was a polytrauma. That wasn't the common injury mechanism in Kenya. But this particular gentleman had an open tibia fracture. So his shin bone was sticking through the skin. His ankle was sticking through the skin. And his arm bone was also broken and sticking through the skin.
Jesus.
And then another kid who had crashed a motorcycle and he broke his hip. And these are all like relatively young people.
Yeah.
High energy type things. And so I show up thinking I'm going to be just hanging out, drinking tea with the Kenyans and waiting to start work until we move to Zimbabwe. And all of a sudden I've got this like 16-hour day of
surgeries.
Dude. So
that's like the most, it's not like you just jumping into some, fixing a car or something. You're jumping into like fixing people.
And fortunately, like I said, you have lots and lots of education, but the difference is that you're totally responsible and you feel that the weight of that.
Yeah.
So I stayed up basically all night prepping for the cases.
Oh yeah.
And got myself so I was confident and ready, and so everything went really well. But there's nothing quite like it,
Fuck, man. It seems like the amount of stress that could. I'm sure at this point you're probably like, no big deal, I can go do an ACL. Or do you still get stressed?
I think the weight of knowing each individual that I'm taking under my care and the responsibility for taking care of them still weighs on me.
Still stressful, yeah.
I mean, I think it's important to be stressed. Stress
Yeah, for
drives
sure.
perfection. Stress drives, performance and everything. It's like if you suddenly weren't stressed out at if a track star wasn't stressed out at the start line, then they probably wouldn't be a very good track star.
Right.
Or for very long,
Or
right?
a track star.
Yeah, it would not be a star at all.
Yeah.
And as a surgeon, you need to continue to feel that stress because the second that you put anything into, just like relaxation mode,
Yeah.
you're gonna make mistakes.
Yeah.
And you're gonna, if you put it into cruise control, then you're not gonna know about the new techniques,
Yeah.
And so I still stress about it and think about everything with each case that I'm doing. So
That's awesome, man. I mean, I don't know how much time you got, but I could.
yeah.
So you go to Kenya, you go to Zimbabwe, you come back.
We actually, Robert Mugabe's, was the president of Zimbabwe at that point in time.
Okay.
And everything just fell into a corrupt mess. So actually what wound up happening was while we were in Kenya, they basically told us we were going to have to pay a ton of money and I wasn't going to be able to be an orthopedic surgeon while I was there. So I was going to have to basically be kind of like an intern or a medical student running around helping the OBGYNs and the pediatricians. And we were like, that doesn't really seem like it's an effective use of a year where I'm donating my time and losing a ton of money to do it. And so over time, it became apparent that was not a good situation for us. And simultaneously, and this was completely insane, while we were in Kenya, all of the doctors went on strike.
Oh, Jesus. For
90% of the hospitals. So for 100 days, there were no physicians working in 90% of the hospitals in Kenya. But our hospital was working. So if you imagine all of
just the influx of people,
the influx was massive. So it wound up being just, perfect providence that we were there at the time and everything fell into place and it was an incredible experience. But I think your question was, what happens after that?
Yeah, you come back to the States and you've been working, I'm guessing there's different standards and just different work environments.
I went from Kenya I went and did my fellowship at a place called Curlin Jobe, which is sort of like, it's like the pinnacle of orthopedic sports medicine. Okay. So they take care of, historically they've taken care of the Dodgers, the Lakers, the Ducks, the Kings, the Rams. They took care of USC for a long time, for the football team, or some of the doctors did. And so it's like also all the celebrities, like you name it,
Can you say anybody that you worked on that's like super famous?
Well, I probably can't say, but...
But you've worked on somebody that's...
I mean, if you look at... So the guy who I trained under is a guy called Neil Elatrosh, and if you look him up, all the people that he,
Yeah.
Like there have been articles where they talked about like he operated on... Kobe, this is public knowledge, but he operated on Kobe Bryant. He operated on a lot of these, just like if you think like Tom Brady had his ACL reconstruction done by him, and then
so this is like the guy.
He's the guy.
Yeah.
And
he's okay.
So you train. So you go from basically rural Kenya, where the work is at least is meaningful, right? Because you're taking people who are unable to walk. They basically, if you don't fix a femur, there's a huge mortality rate. Those people wind up dying very quickly because they can't take care of themselves. They continue to bleed. They have infections, whatever. To a place that's like Hollywood, La La Land, but I think it was helpful for me because it gave me a lot of perspective as I went into that, knowing exactly what I wanted to get out of it.
God, that's got to be such a trip to go from.
Yeah. And it was an awesome experience.
But super stressful in both ways, in two different ways, right?
Yeah.
Like you're out in the middle of nowhere
doing
surgeries on people that if you don't, like they could die or they might not walk again.
Yeah.
And then you come into LA with people that have more money than you could ever imagine. And like the amount of pressure on that, like that you have to do a good job or they could just ruin your reputation or sue you or whatever the fuck.
Exactly.
And,
God. I think the interesting thing that I learned about being up there is, or kind of dealt with there, is there's there's sort of this perception that there's a secret type of medicine that really rich people can afford.
Right.
And sometimes, like when you talk about stem cells, sometimes people tap into that perception to sell things for really expensive that aren't actually proven treatments.
Yeah.
You know what I mean?
Yeah.
At Curl and Joke, we wound up having to sort of like tell people that is not actually the case. You know what I mean?
Like just because you have money doesn't mean you have access to something.
There's not like there's not like a plasma ray that reconstitutes your ACL or something. You wind up being subject to the same techniques that we have because this is the pinnacle of medicine. Right?
Yeah.
So,
just any celebrities just get pissed like, what the fuck? I thought I could.
Yeah, I mean, yeah. But, most actually funny, the celebrities were really, everybody who we met was super nice, super low key.
Yeah.
But, yeah, I mean, I think that sometimes there's a perception in most things in medicine that, I think that you have to choose your doctor wisely, your surgeon wisely, so you have a good relationship and you have like things that I do personally is I was mentioning, like, I work on the editorial board for this video journal of sports medicine, and I do a lot of paper reviews, and it's not like for prestige or anything like that. It's to try and keep myself on top of the game.
Yeah.
The stuff that I learned in residency, none of that is necessarily what I do exactly anymore because I've continued to progress and evolve, and even from the start of my practice, I've continued to progress based on research and whatever and new techniques that have come out to try and make surgeries better. So I think it has more to do with choosing somebody who you have faith in and who has a good reputation than anything else.
Yeah, I mean, a large part of the job has to be the ability to build a relationship with your clients, right? And like kind of tap into the psychology of like what's going on. Like there's all these like sports psychologists now that, I mean, if you're a top athlete, you're in high school and you start to, get looked at by colleges and stuff, like for a young kid, that's like a lot of pressure. But then like being a top athlete in high school or college, having all of that pressure and then adding an injury to it is like,
it's huge.
Especially if, I don't know, there's so many athletes that literally come from nothing. They're the best running back. They hit the most home runs, whatever.
Yeah.
And so there's all that pressure.
Yeah.
And then you throw an injury in there like there's so many situations where like literally 3 months from that point, they could have been drafted into the NFL and made $100 million. Right. So I'm sure you probably experienced some situations like that working. What's the guy's name again? The guy up in LA?
Neil Elitrop.
Yeah. I'm sure there was stuff like that where, you got to work through it in a way that's like, you don't offend somebody or you like make them feel good about, doing surgery, shit like that. It's more than just.
And I think sometimes that pressure that you're talking about, we'll see what's called psychosomatic, pain, right?
Yeah.
You'll see a young kid who's, like the first thing you walk in the room and the first thing that you're told is that this kid is the next fill in the blank.
Yeah.
Just so you know, this kid is like really good, and you can see the parent is telling you that, and I think that it's really important to try and help to support those kids.
Yeah.
Because sometimes that pressure is just crushing.
Yeah.
So, and also trying to differentiate between, like the real injuries and, because you don't want to operate on a kid who's got pain, who maybe is having some of that pain as a result of all the pressure that they're experiencing from trying to be the next top guy. But I do think, I think it's, you mentioned the relationships with the people, and I think that's what it's all about. You have to build the trust so that you can move forward and have honest conversations like the one you're talking about. Maybe you're not going to be in the NFL.
Yeah.
Maybe we need to focus on the future, or this is a little bit of a risky procedure. I need to like have that I have your best interest at heart because there's some risks that are associated with it.
For sure.
You know what I mean?
Yeah.
And I think we make an investment, and that's why it's important that you know who you're working with, because the surgeon, you have to have faith that the surgeon is acting in, in your best interest and knows who you are, is taking the time to get to know who you are.
Yeah. Gosh, man, such a crazy world. What's the most like common reason, or where do you see like the most injuries coming out of? Is it like youth football or basketball or soccer, or just like random end of the day ski injury? Like, what's the thing you're like, this one again kind of deal?
It's funny is basketball for some reason winds up causing a lot of injuries.
Yeah.
I don't know why it is, but I see a lot of ACL tears, and I see actually a decent amount of Achilles tendon ruptures.
Oh, that's a fucking gnarly one, huh?
Yeah. And then pickleball is a favorite because everybody's so into it that they don't want to stop playing.
Yeah.
You know what I mean?
Yeah.
Like, people just kind of keep playing because it's like an addictive sport. So it's not like massive injuries, but I do see a lot of people who have knee injuries or whatever because they play like twice a day, 4 days a week or something,
Oh, shit. I could see that one spinning out a lot of injuries like in the older ages because it's so popular with, people that are retired.
Yeah. But I think the comparison point is it's fun to see like people, because I get to know my patients for like a longer period of time oftentimes. They might have an injury to their shoulder and then they'll come back in, a couple of years later with a knee injury. And you see people who get really into something like pickleball as they get older, and you can see them just kind of come alive when they're talking about it.
Yeah.
So I feel like seeing the passion, the fire is pretty exciting.
That's funny. What about surfing? Do you have a lot of injuries from surfing?
I do. I think I have a particular, obviously, I'm a surfer. I live in Cardiff, and so I spend a lot of time like thinking about surfing injuries and have looked into it a lot. And I've had a couple of things that were sort of interesting. Like I had maybe 2 years ago, there was a swell that came through, and within I had one clinic where two guys who had been surfing, basically pulling into a backside barrel, grabbing the rail and tucking into kind of a tiny barrel. They're regular. The front foot is kind of buckled in to try and crouch into to a barrel. And they both had the exact same injury doing that. They tore their meniscus and flipped it into the notch of their knee. So completely flipped it over. Like, we talk about bucket handle, right? It's attached at 2 points, and you can flip it to either side.
Yeah.
In a meniscus, it should never do that. But when you have a bucket handle tear, it flips to the other side.
Dude.
So I had these two guys who were going left, probably within a mile or two of each other, same day, same swell,
same thing,
same exact maneuver, pulling into a backside barrel with a rail grab, and just like pop. And so it's kind of interactive. But mostly I feel like I see some ACL tears from that, from kicking out of waves a lot, or
and like landing on the board,
or just sort of like an awkward thing where they go to jump off of a wave and land with your knee like hyperextended. If you're surfing pipes and there's like some of those like inshore holes and stuff where you could drop off. So I'll see some of that kind of stuff. But
do you see a lot of shoulder injury from surfing or not?
Less than you'd expect. I've seen a couple guys who had shoulder instability where they were likely to dislocate their shoulder. They had dislocated their shoulder a couple times before, and then they'll be out in a big swell, and then something happens where they dislocate it again. But I almost feel like sometimes the shoulder injuries wind up being more chronic, overuse type injuries.
Right.
But I think surfers tend to strengthen their shoulders pretty well.
Yeah.
Just because it's, the repetition of paddling is sort of a lot of that lower weight, higher repetition type of things that we're talking about.
Yeah.
Where you strengthen your rotator cuff.
Yeah.
So if you're like if you're surfing a lot, you'll have wear and tear injuries, but it tends to be less of the all of a sudden big problem type of traumatic injuries.
Yeah, that's one thing that Marcus was like really good at helping people with, I think, is that so many people think like shoulder and just like the overuse of it, but so much of it is tied to your lats and other muscles that like strain.
Yep.
And being able to, like, same thing that he'd help me with my knee. Let's roll it out, let's stretch it, whatever, figure out like if we can, solve the problem without having to go get an MRI or whatever.
Right.
so much. Like I used to get shoulder tightness in my right shoulder, and after Marcus, it's like, I just know I need to roll it out because it's something else that I worked out that's like, you know, shrinking or whatever. And it's just pulling on a certain aspect of it.
I think a lot of the different parts of the body are like that too.
Yeah.
You think about it, and like the shoulder doesn't exist in isolation.
Yeah.
Right? Because the shoulder is your humerus and the glenoid, which is the ball and socket.
Yeah.
But that's attached to the scapula, which is your shoulder blade,
Yep.
which rides along your ribs, and it's stabilized by all these muscles that make up what's the periscapular stabilizers. And so your shoulder blade is moving around all the time as you're moving your arm.
Yeah.
So if those aren't strong, if your rhomboids and all those different things are not functioning the way that they should, you're going to have shoulder pain. So there's a lot of things that, like those exercises that Marcus is talking about, can be huge for making your shoulder function better. And you can totally get rid of the need to see me.
Dude, just hanging from a pull-up bar. Mm-hmm. Oh my God. Like the relief that can provide after you've done whatever exercises or surfing. Yeah. I don't know what exactly is going on, but it's incredible. Like you go do that and like everything seems to just like open back up. And you're like, holy crap.
Well, it's funny too. If like I've heard Dave talk a little bit about some of the shoulder massage stuff and the stretching and whatever. That exact thing is what the athletic trainers for professional pitchers will do. Yeah. That is literally exactly what they will do. And they'll, it's a little bit of torture. They'll be like getting up in it. I'm sure that it's happened. Has he worked on your shoulder at all where he's
oh my God, dude.
And it's like torture. And then at the end, the shoulder is so much more functional.
Marcus will have us do this thing where he'll basically, I started using it like the Theragun to hit my pec, but like basically you have your thumb and it hits your hip and then you open it like this and you rotate, and while you're hitting all the different parts of your pec, and you do that on each side 20 times, dude, it's crazy. Yeah, it's insane. And then like the stretching against a wall and just opening up your pecs, it just changes everything. I don't know. It's nuts. He's awesome. I think,
But I think it speaks to what you were talking about before, which is that, like, if you think about the professional athlete's rehab for an ACL reconstruction or a, labral repair in the shoulder or something like that, they have that constant attention of exactly that type, where every day they're going in for work on their shoulder, for therapeutic, massage, whatever, and exercise. And that's the type of thing that you'd aspire to for every single patient that you go through, right? And so, trying to figure out ways to, and I think you in the future, you'd envision a way to, to take advantage of technology or whatever to try and provide some of that, even though you can't have a Marcus or an athletic trainer from, the Padres coming and working on your shoulder every single day after a shoulder surgery or whatever, to be able to have some sort of technology that helps you work through some of that stuff yourself and really buy into it. I think that you can. There's somewhere in between the being completely left alone, like you felt like you were afterwards. And
for sure, I think what to me, like where it all kind of comes together is like being super aware of how your body is feeling, where you feel like you're holding stress. For me, like I know that I tend to lean more on my left leg just from habit 17 years ago of taking weight off of my right knee.
It's wild, isn't it?
Which is a freaking trip. And Marcus is like, we need to address this. Like you can't stand with most of your weight. It's going to fuck up your hip. Yeah. It's going to put your back in a weird position, all these things. So being super aware, and then, learning about the tools that you can use to, I don't know, I guess for lack of a better term, like iron out your body and get all the wrinkles out. And it's amazing how much better you feel. Yeah. And then when something does happen, like a traumatic, ACL injury or whatever, like it's very obvious that something is more severe than just your muscles are tight or whatever. Because, for top athletes, I feel like a lot of times they don't even, like I've heard stories of like hockey players not even know that they tore an ACL because their legs are so strong. And so if they were just, I don't know, maybe if they were more aware of their body in a certain way, like they could identify it faster.
Oh, absolutely. Whatever. And I can tell that when I have someone who comes in, like I have a sense very quickly of how in tune with their bodies people are. And oftentimes they won't tell me that they're in tune with their bodies, but I can sense it. Like the way that someone describes what's happening with their knee. You know, there are people
like sensations or whatever.
Yeah, there are people who come in and they'll be like, where does it hurt? You know, I always ask that. And I try and force people to tell me exactly where it hurts because it makes a huge difference. And sometimes just by having that story, like I said, I can already identify what the injury is without even having to lay hands on it. I can start to develop my theory of what's going on. Yeah. And sometimes you'll ask people and they'll be like, I don't know, like somewhere like, you know, they'll point to their whole leg. Totally incapable of describing even remotely where it is. And then you have people who are like, well, it's sort of like a, you know, it's a pinching sensation when I flex my knee. And it's like 2/3 of the way back along the outside of my joint line. You're like, you're paying attention. You know what normal feels like and you know what abnormal, you know, feels like. Totally. And then they're able to sometimes head off things beforehand and, you know. Yeah. I think you're absolutely right.
Yeah, it's a thing that I could like learn about and talk about for maybe not talk about with any sort of like valuable information, but like I could always sit here and just ask questions about it. It's just a crazy thing. Yeah. But I know you got a little baby at home, so I'm gonna let you go.
Awesome, man.
Yeah, dude. Thanks so much for coming by. It's you're obviously super busy and
well, it's fun to talk over this. Stuff, you know.
So I really appreciate it. It's helped me. Hopefully it helps somebody else and like kind of moving forward with the old wheel.
I think we can get you back at tip-top shape. We'll get you at least to 95%.
Cool, man. Well, dude, thank you. Awesome, I appreciate it. And we'll talk soon.
Awesome.